Hello friends, my name is Dr. Saeed Kazmi. You're watching my YouTube channel, and in today's video we will be talking about knee injuries in children, and this is going to be a complete guide for you to diagnose and manage knee injuries in children. Now, sports and accidental injuries in children are very common. Why? Because they are active, they play sports a lot. They are involved in contact sports like football, rugby, volleyball, cricket, hockey, so on and so forth. So they are very much prone to accidents, and most of these accidents, they do involve the knee. So around like 5 to 6% of all the injuries in children, they do comprise of knee injuries, and we do see like it on a daily basis. So as I told you, that the commonest mechanisms causing knee injuries in children are sports, contact sports. But apart from sports, falls from a height or from stairs or from like any sort of height, that can also cause knee injuries. And apart from that, rarely knee injuries can also be caused in children by motor vehicular accidents. Now, why they're so prone, like why knees so prone to injuries? Number one, because in children there is a rapid growth. There are growth plates on both sides of the knee joint, and obviously that's the weakest part of any bone, and that's why if there is injury around the knee joint, that can affect it and can have deleterious effects on the health of the child. Also, they've got a bit of ligamentous laxity, so that's why stability can sometimes become an issue, and they are more prone to ligamentous injury as well. And some of the injuries themselves have got a unique injury patterns. For example, playing rugby and football, there are particular type of injuries which would cause, like for example, anterior cruciate or posterior cruciate ligament injuries. Now, most of the time in children, most of the injuries, they are soft tissue injuries. I mean, they involve ligaments, and in ligaments you must understand that the four common and important ligaments: anterior cruciate, posterior cruciate, and then medial and lateral collateral ligaments. They are very important structures and can easily get injured um, in the injuries. Apart from them, sometimes we do see avulsion injuries in children as well, in which part of the bone is chipped off either from femur or from the tibia or fibula or from the patella itself. Moving on to knee injuries, it's very important for you to understand the anatomy of the pediatric knee. So the pediatric knee, as you can see in this picture, it's basically a joint which is formed by the union of the femur bone superiorly, tibia and fibula inferiorly. So femur is on the top, tibia and fibula is at the bottom, and then we have got ligaments which attach, like from on the medial side you've got the medial collateral ligament that attaches the medial part of the femur with the medial part of the tibia, and then we have got the lateral collateral ligament which attaches the lateral part of the femur with the lateral part of the fibula, and then we have got crisscrossing ligaments inside the knee joint which are known as the anterior and the posterior cruciate ligaments, and they are very important for stability of the knee joint. And then we've got two cushioning pads as well, like which helps in moving and reducing the friction in the knee joints, and they are known as the medial and lateral menisci depending on which side they are found on. So knee joint is a sort of a very important joint, weight bearing joint formed between the union of the femur, tibia, fibula, and then anteriorly discovered by the patella as a floating bone as well. And remember, four important ligaments: anterior and posterior cruciate ligament, medial and lateral collateral ligaments, and the two menisci. So four ligaments and these two discs, total of six structures. Very, very, very important in order to understand knee injuries in children. Moving on, common types of knee injuries. So common type of knee injuries, by and large, the most common is patellar instability, which can either lead to patellar dislocation, we also call patellar femoral dislocation, or subluxation. Dislocation is frankly dislocated out of its place, goes laterally, and subluxation slightly moves, like there's a bit of play in that. And then you can have like these ligament sprains and tears. In sprain, they just get stretched. In tears, they can have partial or fully, like sort of the ligament can either be like sort of torn in two pieces, or most of the times like there would be some fibers which would be torn in between. So again, that can occur in any of these ligaments: anterior or posterior cruciate ligaments, or medial and lateral ligaments. Then we have got the avulsion fractures as well. Avulsion fractures are a bit more common as in children as compared to the adults, because the tendons themselves are quite strong as compared to where they're attached on the bone. So sometimes the shearing forces, it like takes the chip of the bone off as there is a violent force. So you can have like avulsion fractures on the femur, you can have avulsion fractures on the tibia or on the fibula. So we call them as avulsion fractures, and in a moment we will discuss them all. Then we've got the medial, we have got the meniscal injuries as well, which are two cushioning pads, so either the medial or the lateral one. These are usually caused by twisting injuries, and they can also get injured, and part of the soft tissue injuries or ligamentous injuries of the knee joint. And then there are certain injuries which are basically not like sort of true injuries, but they are overuse syndrome. Somebody who's been using knee too much, either because they're involved in sports or running or jumping, so they can get some sort of like a traction apophysitis, and two important entities here in like overuse injury patterns or overuse syndromes causing pain in the knee joint are number one, what we call as Osgood-Schlatter disease and the Syndig-Larsen-Johansson syndrome, and we will discuss them later on. So let's talk about patellar instability. So patellar instability is one of the most commonest knee injury which we see in practice. So mechanism most of the time is trauma. So not everybody gets like because of trauma they get like a patellar dislocation. Some kids have got shallow trochlear groove, or maybe having a bit of high riding patella which has got more sort of a play in that, and they are more prone if there is an injury from, especially from the medial side, your patella can move out of its place to the lateral side. So usually they're playing sports, and all of a sudden, because of an injury, rough tackle, or sudden violent movement of the knee joint, they usually hear a popping sound. So like the patella pops out of the place, goes laterally, and then depending on the situation, it can like pop back as well, or it can just stay there. I mean, if it stays there, the child cannot move the knee. They're usually screaming because of pain. It leads to swelling, and in the picture you can see that if you look at that particular condition, so you can see because the kneecap is not in place and it's slightly moved to the, so you see an obvious deformity of the knee joint. So the diagnosis is mostly clinical, but you do an X-ray to actually, I mean, if you, the question usually is asked like, if you can diagnose it clinically, what's the point of doing an X-ray? Because sometimes it can lead to sort of a chip fracture of the patella as well. So it can either, because it moves laterally, it can grind against the lateral surface of the femoral condyle, so you can have a chip fracture on the lateral condyle of the femur, or maybe on the medial side of the patella. So that's why it's important to do an X-ray whenever there is a dislocation per se, or dislocation followed by a sort of a spontaneous relocation. So remember, in X-ray you might see that there is an actual dislocation, or if there is a reduction, you might see there might be sometime an osteochondral fracture, avulsion fracture. Sometimes we have to do MRI as well if the injuries, like X-ray is not a very good modality in showing like ligamentous strains and sprains. So sometimes we have to do MRI as well to look at the extent of the ligamentous injury. Usually management, you have to reduce it. If it's not being spontaneously reduced, what we normally do is we give some form of painkillers to the child, like you can give them Antonox or strong painkillers, and then you have to extend the knee. So as you are extending the knee, you can just flick the patella back into place. So usually hyperextension of the knee leads to spontaneous reduction of the patellar dislocations. That's a procedure which is usually done in emergency departments, and then it is followed by putting them in a knee brace. We call it a cricket pad splint. So that has to be put together with a non-weight, like they have to be put on non-weight bearing, like give them a pair of crutches, and then they can be followed up by the orthopedics in the fracture clinic. So the treatment is number one, manual reduction by hyperextension of the knee, flicking the patella back into place, bracing, and then once everything settles down and there are no fractures, then obviously they have to undergo physiotherapy. And some people, they have got this repeated patellar dislocations as well, so they need to develop their muscles. So the hamstrings and the quadriceps muscles have to be developed, so that that sort of a ligamentous laxity in the knee is overcome by the strong muscles, and they are able to hold the patella back in space, especially when there are violent forces. So physiotherapy for repeated patellar dislocations. Moving on to anterior cruciate ligament injury. Now, anterior cruciate ligament is one of the most commonest and important ligament knee injuries in children. Now, the mechanism mostly is non-contact. Non-contact means, like all of a sudden, as the foot is fixed and there is a twisting movement. So if there is a twisting movement in the form of a dynamic valgus, followed with the femoral adductions. The femur goes inside, and there's a dynamic valgus like stress on the knee that can lead to sort of a tearing, either partial or complete tearing of the anterior cruciate ligament. So like cutting movements or pivoting movements, like where the foot is fixed, and sudden violent movements of the knee joint, and these are usually non-contact. I mean, nobody has kicked you, nothing, but because of a sudden cutting or pivoting movements, the shearing forces just like tear the anterior cruciate ligament. So all of a sudden with these type of movements, they would hear a pop, because like if there's a one and it's like stretches, so they hear a sort of a popping sound, which means some fiber have been torn, and it rapidly leads to hemorrhagosis, because this is an intra-articular ligament. So it would lead to bleeding inside the knee joint. So knee joint would be very painful, very swollen in the initial phase. So the two tests that are usually done to diagnose anterior cruciate ligament, the more sensitive is what we call as Latchman test. So Latchman test, what you do is basically you flex the knee joint to 20 to 30 degrees. So you hold the thigh with one hand, and you try to push and see if there is any play in the sort of movement of the tibia over the femur. So if there is like sort of a movement or a slacky or play, holding the knee in 20 to 30% flexion, then we call it Latchman test positive, and that is like sort of quite a sensitive test of anterior cruciate ligament tear. Or the other one is the anterior draw stress. So anterior draw stress has got slightly low sensitivity. In this, what you do is you have to flex the knee to 90-degree, and then you try to push, like put your thumbs on the knee and try to bring the tibia forward and see if there is a sort of a movement of the tibia forward on the femur. So that is anterior draw stress. So the difference between Latchman and anterior draw stress is that in Latchman you have to flex the knee 20 to 30-degree, you hold the thigh, and then you try to move the tibia on the femur, while in anterior draw you actually flex the knee to 90-degree and then do the maneuver. Axes are very important in anterior cruciate ligament, because and the thing is that the anterior cruciate ligament is attached like on the anterior surface of the top, like intercondylar surface of the tibia. So sometimes it can like sort of as it ruptures, it can pull a part of the bone on, so it can cause this spinous process fracture of the tibia as well. So it's very important to do x-rays, or it can be associated with like some other avulsion fractures of the knee joint as well. So x-ray is very important to see if there are any sort of fractures associated with the anterior cruciate ligament. uh, if there are, then usually MRI also be done, because MRI will give you the extent, the actual extent of the ligamentous injury as well. Coming down to the management, so if you know it's anterior cruciate ligament, so usually in the very first instance there is usually non-surgical treatment. So you will do like bracing, immobilize the knee in like a sort of a brace or in a cast, and then once the swelling has subsided, the inflammation has gone down, then it depends on the extent of the tear. So it will either be physiotherapy, or if the tear is a bad one, then it might need sort of surgical reconstruction, and an orthopedic surgeon would have to do a sort of operative reconstruction. Then coming down to posterior cruciate ligament injury. So posterior cruciate ligament injury usually occurs when there is a direct blow to the anterior tibia or hyperextension. So usually these players would be either playing football or rugby, and somehow what happened is that there is a hyperextension with a sort of stress forces on the knee joint, as you can see in this picture, and these types of injuries would sometimes lead to posterior cruciate ligament injury. So it's either a direct blow to the anterior tibia or a sort of a hyperextension leading to this injury. So again, it would lead to severe swelling, severe pain in the knee joint, unable to weight bear, and usually the clinical finding is the posterior sag sign is usually positive in this, or the quadricep active test that's also done, and that's also positive in case of posterior cruciate ligament. Again, x-rays are done because it might be associated with avulsion fractures, just like the anterior cruciate ligament. Posterior cruciate ligament can also cause avulsion fractures, so it's very important to um, have an x-ray. And even if the x-ray is fine, at some point in time an MRI would need to be done to see the extent of the actual ligamentous injury. Again, the management is like in the initial phases, it's non-surgical, like either they have to be casted or put in braces, immobilization, and once the inflammation and the pain and the swelling subside, then it's either physiotherapy, and depending on the nature of the ligamentous injury, it might be a sort of a surgical repair or reconstruction. Now coming down to the ligamentous, like the medial and the collateral ligaments. Medial collateral ligament is on the medial side of the knee, attaches the femur to the medial side of the tibia, and the lateral one attaches the lateral side of the femur to the lateral side of the fibula. So medial cruciate ligament injury is usually caused by valgus force to the knee. So obviously if the knee is and there is a force, valgus force, like toward the outside, and that would lead to stretching of the medial collateral ligament, and some of the fibers can torn. And if it is torn, like again, because it's attached to the femur and the tibia, you can have like sort of avulsion fractures either on the on the medial side of the femur, or on the medial side of the what you call tibia as well. So the fracture, usually if it occurs, leads to a chip fracture on the medial side of the femur, we call it a stida fracture. And if it causes a sort of a fracture on the avulsion fracture on the medial side of the tibia, we call it the reverse secant fracture. So these are the avulsion fractures which are associated with medial collateral ligament injury. So again, there would be a lot of pain on the medial side of the knee. There might be a bit of joint instability, and obviously if you palpate that area, that would be very tender. X-ray is also important, because if there are any avulsion fractures, that would be picked up, and if not, an MRI has to be done, because that would give you the actual extent of the injury to the ligaments. Again, as the management comes down to bracing, putting them in sort of an immobilizing them, putting them on non-weight bearing, and then later on physiotherapy plus minus surgical reduction. Lateral collateral ligament injury, basically this is caused by the opposite varus forces to the knee. So like the knee forces coming from the lateral side, pushing the knee inward. So that would lead to stretching of the lateral collateral ligament, and again it can get torn either like close to where it is attached on the femur, or where it is attached to the fibula. So there will be like again pain, maybe inability to weight bear. There might be joint instability, and there would be quite like if you palpate over the lateral collateral ligament, there would be a tenderness. X-ray, MRI, again the same principle. X-ray to see if there are any avulsion fractures. Like sometimes the top head of the fibula can get fracture, arcuate sign, or there could be fracture on that side of the femur, like the lateral side of the femur as well. So management again is like immobilization, bracing, and then once swelling and everything goes down, then physiotherapy plus minus surgical reconstruction. Now coming down to the some of the avulsion fractures. So avulsion fractures, as I told you, these avulsion fractures usually occur because the ligaments, when they are attached on the bones, the ligaments are quite strong as compared to the attachments on the bone. So when there is a violent force, the ligament actually, instead of tearing, can take a chip of the bone off. So anterior cruciate ligament or posterior cruciate ligament attachments can lead to chip like avulsion fractures wherever they are attached. So depending if if there is fracture on the medial side of the what you call medial side of the femur, we can call it the secant fracture. Or if there is what you call the fracture on the medial side of the fibula, we call it the reverse secant fracture. And similarly, if there is a fracture on the lateral side, we call it the secant fracture. So reverse secant is on the medial side, secant fracture is um, on the lateral side. So these are some of the fractures, and sometimes you can also get like fractures in the patella as well, patellar sheath fractures. Again, these are caused by injuries or by sudden violent forces, like violent contraction of the knee in sports injuries. So again, most of these avulsion fractures would be associated with ligamentous injuries, and later on MRI have to be done to see what is the extent of the actual ligament, because ligaments would not be visualized on X-ray. You can see avulsion fractures on X-ray, but not the ligamentous injuries. Then the meniscal injuries, medial and lateral meniscal injury. Again, because these are cushioning pads, which are there in the joint space between the femur and the tibia. So usually the mechanism is that there is a twisting or like hyperflexion, hyperextension injury associated with twisting. So again, these are mostly sport injuries, and these children would be, having severe pain, unable to weight bear if they, injure their menisci. uh, Maybe leads to lock knee as well, not able to, move knee at all. Clinically, you will see that the joint line tenderness over the knee joint. Usually they've got very severely limited range of movements, and the McMurray test is usually positive. So McMurray test, I will discuss it in some way. That has to be, the knee is flexed and extended, and a sort of it's rotated inward and outward, and you then you see if there is any sort of a play in the movements. Again, imaging gives you limited sort of information. MRI is actually the gold standard, and again they are managed either non-surgically or surgically. Then coming down finally to overuse injuries. And overuse injuries, two three things, mostly, uh, you know they are caused by repetitive movements of the knee joint, so like jumping, running, kneeling. One special entity worth mentioning is Osgood-Schlatter disease. So Osgood-Schlatter disease, what happens is where the patellar tendon attaches on the tibia, the repetitive, sort of a micro trauma because of repetitive jumping or running or something, it leads to microfragmentation of the tibial tuberosity. That leads to a bit of swelling over the tibial tuberosity, pain, especially when you press on that particular area, and that is what we call as Osgood-Schlatter disease. So X-ray would show you a bit of fragmentation of the tibial tuberosity where the patellar tendon attaches to the tibial tuberosity. Uh, because this patellar tendon is coming from the patella, sometimes what happens is that these microfractures might be on the inferior pole of the patella as well. So instead of happening on the tibial tuberosity, they are happening slightly above where the inferior pole of the patella is located. And if that is the condition, we call it as Syndig-Larsen-Johansson syndrome. So Syndig-Larsen-Johansson syndrome is similar, like it's the same, like sort of a traction epiphysitis, but this time it is occurring at the inferior pole of the patella, unlike the Osgood-Schlatter disease in which it is occurring at the tubal tuberosity. So they are all traction epiphysitis, and they are treated conservatively by rest and by painkillers, and maybe sometime by changing the profession and maybe stopping sports altogether. So this was all about the knee injuries. There are a few other things as well, but like for doctor, pediatric doctor, I mean, obviously orthopedics have got a more broader understanding of knee injuries because they are the specialists who deal with all these things. But as a pediatrician, you should be able to understand these are some of the common mechanisms and knee injuries, soft tissue injuries, ligamentous injuries, and avulsion fractures, which you can commonly see in your practice, and you should be able to advise them appropriately. Hope you have liked this video, and if you've liked it, give us a thumb up, share it with your friends. If you've got any questions, put it down in the comment section below. Thank you very much. Bye bye.